Good afternoon. I have no disclosure, and I would like to start my talk with these two pictures. On your left side here is the Montreal General Hospital where I work, Montreal, summertime, of course. And this is a patient who underwent laparoscopic hemicolectomy on post-op day 1. You might ask, what's the relationship between these two pictures? So obviously, this patient had surgery in this hospital. And the second relationship is a story I'm going to tell you. On post-op day 1, I went to see him. I gave anesthesia to him. And I couldn't find him at around 7 o'clock before starting my OR. And I thought he was in the bathroom or somewhere else. And I went back around like 11:30. And I met him, not in his room, but here, that's a room that actually now turned out in a room for patients to eat, watch TV, sitting, reading a book, no IVs, no Foley, drinking water. And of course, you walk to this room. Then I went back to my OR, and I had the same surgeon that operated on him, and I discussed the case with him, and I asked him, like, oh, Mr. S is doing pretty well. And he told me, do you know the story? I said, no. So basically, he woke up at 6 o'clock in the morning without saying anything to anyone, no nurse. He decided to get out of the hospital. And you see behind the Montreal General Hospital, there's this big hill. He climbed the hill and then went to watch the landscape from the hill. It's beautiful. And the nurse, of course, freaked out because they couldn't find him. And I couldn't find him as well. So this to say is, how can we make sure that patients who have comorbidities, such as Mr. S, can recover in the same way without complications? So my first question, try to answer, can we identify patients' risk factors that can increase their odds to have postoperative complications? And second, can we estimate the preoperative risk in order to reduce it and facilitate surgical recovery? So when we look at identify patients at risk of morbidity and mortality, this is a recent study, is a 7-day cohort study done in Europe looking at mortality across nations, European nations, elective and non-elective surgeries, big sample size, and their crude estimated mortality was approximately 4%. It's pretty high, higher than what we expected. And even after adjusting for potential confounders across different type of care across countries, you can see there's a huge variability. And as a landmark, as a reference point, has been taken the UK, that has in 2006 a reported mortality of 1.9%. There are nations that are doing better, nations that are doing not so good. What about morbidity, complications? This data come from the NSQIP database, large US database collecting perioperative data and postoperative morbidity and mortality. And from 2006 to 2011, you can see there's a trend decreasing complication approximately from 22% to 25% to 24%. However, when we look at type of surgery, we can see that there's, again, a huge variability in complication ranging between 20 and 45%, with a mortality rate of approximately 2.1% in 2011, and with at least 24% of patients that experience at least one complication. So our surgery are not all like the surgery of Mr. S. We have to find a way to identify patients who are going to experience complications. And why is important having a complication? You already seen this study. Despite mortality hasn't changed over these years, having a complication within 30 days reduced by 69% the chance to survive at 8 years. So your life can be reduced from 18.4 years to 5.6 years after surgery. So complications are important for patients and can determine their survival after the surgery. There's a variety of risk factors, some that are related to patients and some related to surgery that can influence the occurrence of complication and dying after the surgery. And each of these risk factors, some can be modified, others not, play a role in determining the perioperative risk. This study, looking at again at in-hospital mortality across different nations and countries, found out there's a huge again variability in mortality, and that the authors suggest that postoperative morbidity is mainly related to patient's care rather than type of surgery or the entire perioperative care. So can we identify these patients? The American College of Surgeons came out with 15 predictors of high-risk surgery. Again, some cannot be modified, like age. Others are potentially modifiable, such as nutritional status, BMI. Can we quantify the risk? Can we estimate how much is the risk of having a complication after the surgery? This is a table that summarizes the tests that we have available to estimate perioperative risk. Some are very easy to perform, such as 6 minutes walking test, has been associated and validated as a tool to predict postoperative complication. Is basically the ability of a patient to walk for 6 minutes, and measuring the distance, we can convert the distance in metabolic equivalent. More complex, such as the cardiopulmonary exercise test, although requires equipment and is not always available. Furthermore, the specificity is not that great, meaning that if might have a false positive, it means that the patient might still undergo surgery without complication, but if I base my results on the CPAT to do not perform surgery in this patient, might not be a good idea. The P-possum, although was designed mainly to estimate mortality, has been also shown to correlate well with postoperative morbidity and include physiologic variable and operative variables, and they give you a percentage of experience, complication, and mortality. Another predictors that can tell us if the patient is going to have complication are biomarkers. Here, for example, we know from data coming from ICU, from the intensive care, that hemoglobin A1C, even in non-diabetic patients, is a predictor of postoperative complication, mainly infections. So once we identify our patient, how can we reduce their risk to experience a complication? It's not easy. When we talk about optimization, we mainly try to improve a functional reserve. And this is important because functional reserve is important to optimize preoperative medical condition, exercise capacity, and something that we don't put a lot of attention, the psychological status of a patient coming to surgery. Might be depressed, might be anxious, and all of these factors can affect his recovery. So which are the weapons we have available to optimize these conditions? We have pharmacologic intervention, nutritional intervention, physical and mental intervention. And each of them can be used to optimize different aspects of patient's health. I'm going to start with the pre-existing medical condition that is the majority. As anesthetists, we spend time trying to optimize diabetes, hypertension, and of course, each of these topics probably will require a talk, and I'm pretty sure you are familiar. This is American guidelines for cardiovascular optimization and respiratory optimization. The European Society of Anesthesiologists has its own guidelines as well, and they're pretty much similar with a small difference. I will not go through each of them, quite extensive, but I just would like to remind a couple of things. Patients having beta blockers should continue to receive beta blockers during the entire perioperative period, and the class is 1 with the evidence, moderate evidence B. And the benefits of beta blockers in patients undergoing high-risk surgery, such as vascular surgery, and having at least one clinical risk factor for cardiovascular morbidity, is not that great, is still moderate. So the risk and the benefits has to be evaluated for each patient. Routine administration of beta blockers, data from the POISE trial, telling us that it's not beneficial, it actually may be harmful. Another aspect of care, every day, at least 1 million of patients per year receive a stent. There's an average of 1.5 stents per patient. And these patients, most of the time undergoing elective surgery or emergency surgery, are on dual antiplatelet agents. And if you take drug-eluting stents, for example, if we stop both antiplatelet agents at the same time for surgery, the risk to have an intrastent thrombosis has an hazard ratio of 89.78. So it's huge risk. So there are algorithms on how to decide when to stop aspirin or clopidogrel, or when to stop both, or when to use other things. They're not that complicated, but what we need to know is, first of all, the type of stent. Is it a drug-eluting stent or is it a bare metal stent? The time from when the stent was placed is crucial. Bare metal stents have different time from drug-eluting stents, where we can stop at least one antiplatelet agent. And also we need to know the surgical risk, the risk of bleeding. So the case has to be discussed with the surgeon to decide to stop one or both, or when to integrate antiplatelet effect with, for example, IV anti-2B3A protein. If we move away from medical optimization, like 80% of our patients, at least, they smoke. And despite telling the patients we should stop smoking, the patient probably is thinking in his mind, yeah, easy, I'm having surgery, I'm scared, I'm anxious, I actually want to smoke more. But there's benefits, there's evidence showing that quitting smoking at least 4 weeks before surgery improves outcome, and specifically reduce complication, or mainly wound healing complications. This is a meta-analysis that summarized 5 randomized control trials that reported complication and implemented smoking cessation strategies. And they showed that overall complications were reduced, but only when the intervention was started at least 4 weeks before the surgery. The patient had a nicotine replacement therapy, and it was not enough. And they also had to have an individual counseling with the center. So do we have all these tools to help our patients stop smoking before the surgery? In Quebec, for example, there's a free number to call that's going to give you all this type of support. We start to have this brochure in our pre-op clinic, and more than just saying the patient you should stop smoking, we also start giving this pamphlet where they can call, they have a free support and all kind of medical assistance they need. The American Society of Anesthesiologists in their website, again, has material that can be downloaded, phone numbers that can be called, and patients can get support. The American College of Surgeons, the same. So we have tools, and we should spend more time and dedicate our interventions also helping patients smoking, considering that approximately 20% of patients that quit smoking before the surgery, they will stop for good after the surgery. So since quit smoking does not only reduce postoperative complication, but improves outcomes in general in life, that's a good opportunity for our patient to quit smoking. Nutritional status. These are data coming from our pre-op clinic, and we found that approximately 75% of patients are not adequately nourished. 63% here, they were moderate or suspected undernourished, and 8% were severely nourished. Do we measure it? How do we know? We just look at albumin. We know that albumin is something that is not reliable and is influenced by many other factors. There are scores that can be used. This is, for example, we use a subjective global assessment that is validated and has been recognized even in the ESPEN guidelines. And we know that patients who are malnourished, of course, they experience more complications. These are patients who were severely malnourished with a nutritional risk screening tool more than 4. Prospective study of 1,085 patients who were severely malnourished have higher complication than patients who were not treated with the preoperative enteral or parenteral nutrition. So optimizing nutrition in severely malnourished patients improves outcomes. These are the ESPEN guidelines, European Society of Parenteral Nutrition and Enteral Nutrition, on how to optimize the nutritional status. They suggest that if the patient is severely malnourished, the surgery should be postponed at least for 10-14 days and prefer the enteral route over the parenteral route. If the surgery is elective, take the time to optimize the nutritional state of the patient. Again, preoperative anemia is very common in elective and in emergency situations. Do we spend time as an anesthesiologist or perioperative physician to optimize, or we just proceed for surgery? The causes of anemia, of course, all of us, we know. I'm going to skip to these slides. But what is important is that, again, these are data coming from the NSQIP database. 227,425 patients undergoing non-cardiac surgery, elective and non-elective, 30% were anemic. And independently by the severity of anemia, this patient had a higher 30-day mortality and higher morbidity after adjusting for potential confounder. One of the main criticisms that has been made to these data is that anemic patients most of the time are transfused. And we know that the downside of transfusing patients. So in this other study that is a population of specifically patients undergoing colorectal surgery from the same database, what the author did, they look at the entire population anemic, and they saw that the risk of postoperative complication was increased and length of stay was prolonged. And after they removed patients who were anemic but were not transfused, and they found the same results. So even removing patients who are anemic but they are not transfused, accounting for the negative effect of transfusion, the risk is still there. So this is a very nice study showing that even 1 unit of blood from the same database, NSQIP database, can increase the risk of mortality and morbidity. So transfusing anemic patient is not always the answer. We need to know why these patients are anemic, and accordingly to the type of anemia, we need to treat it in different way. Increase mortality and increase morbidity. And more units of blood you give, more these risks are increased. Can we predict patients who might require transfusion? The same authors, using the same database, validated this score, this transfusion risk index that account for type of surgery, patient's characteristic, like ASA, age, type of disease, and physiologic variables such as coagulation, creatinine, and so on. And by adding all these points, they were able to show that higher is the transfusion risk index, higher is their chance to be transfused, saying that because if I know that my patient is anemic and has a high probability to be transfused, if I want to avoid to transfuse this patient, I should treat it medically to avoid the negative effect on transfusion. And this is a recent recommendation from the American Society of Anesthesiology saying that you need to assess our patients at least 4 weeks before the surgery. Correcting anemia takes time. It's not something very quickly unless you give blood. And according to the type of anemia that you have, evaluating ferritin, transferrin, and glomerular filtration rate, you should call for the help of a hematologist or nephrologist, try to optimize anemia. And if the anemia is not corrected, what do they recommend? That unmanaged anemia is a contraindication for elective surgery. So nutritional status is not optimized, we postpone the surgery. We should start doing the same for anemic patient. But what about the other aspect of optimization, such as exercise capacity and physiological status? Do we care? Do we measure these variables before the surgery? If we improve this condition, is there a difference in terms of patients' outcomes? This is a study was done after day surgery case. So even bringing down length of stay to 0 after laparoscopic cholecystectomy, if we measure functional recovery with a questionnaire called SF36, that based on the score converts in kilocalorie per kilo per week, we saw that after 1 month, this patient has basically correspond to the ability of the patients to walk around, to function in his life. After 1 month after laparoscopic cholecystectomy, 46% of the patient did not recover to baseline. So even a single operation with the 0 hospital stay takes a lot of time to recover. And if we plot here, this is graph you already seen, the trajectory of functional recovery before, during, and after surgery, with and without an enhanced recovery program. We see that if we add an enhanced recovery program, in theory, the recovery should be fast. But what about if we take time during the preoperative period, if we use the time that we have before the surgery to optimize the functional capacity in order to further reduce the drop of functional capacity secondary to surgery in order to speed the recovery. And this work has been mainly done by Dr. Carly at McGill, and that recently finished this randomized control trial, actually looking at prehabilitation, so trying to increase functional capacity during the preoperative period versus patients who were rehabilitated but only after the surgery. And they looked at the multimodal program during the prehabilitation and the multimodal program for the rehabilitation group were the same and included home-based aerobic exercise, nutritional counseling with whey protein supplementation, and anxiety reduction exercise. The results, not surprising, of course, patients who were prehabilitated during the preoperative period increased their functional capacity, measured with a 6 minutes walking test. This was their primary outcome. With surgery, function for decrease at 4 weeks, but 8 weeks after the surgery, approximately 2 months after, patients who were prehabilitated actually performed better before starting prehabilitation compared to patients who were only rehabilitated. And if we look at the proportion of patients who improved their functional capacity before the surgery, 54% of the patients were above baseline. This was before the surgery. 23% of the patients in the prehabilitation were at baseline, and 23% of the patients of the prehabilitation were below baseline. And all the prehabilitation performed better than the rehabilitation group. Was true before the surgery, and they have very similar results, statistically significant. Again, at 8 weeks, showing that prehabilitating patients before the surgery improves functional capacity. And the improvement that they were able to demonstrate is a approximately 50-meter difference in your walking capacity. And in 50 meters, you can do a lot of things. You can go to the bathroom. You can go down to pick up something that was delivered to you. This is not something that is not clinically relevant. And sometimes these patients are home alone. They don't have help, and they can really benefit from this type of optimization. So in summary, we are dealing with complications and mortality. Complications occurs approximately between 15-25% of the cases. Mortality is still there. We didn't improve over years. Optimization is crucial, but requires resources, requires time that sometimes we don't always have available, and requires a multidisciplinary approach. As an anesthesiologist, or as a family physician, or as a surgeon, you can't optimize the patient by yourself. You need to share some principle and access to some resources. And we think that more resources should be directed towards preoperative optimization of functional and psychological status based on the results of the prehabilitation. Thank you.